to allow as much time for questions as possible, but I'll just pick out a few key pointers really. So at the moment, you'll see in terms of our 1 to 9 cohorts, we are, what you might suggest, we might have kind of reached a sort of saturation point in some ways. We're sort of hovering around the 70% mark, excuse me, across all those cohorts. And we are making limited progress in terms of, you know, additional people accepting their first dose on a week-to-week basis, going through that activity. We are focusing really on the residual population. So that's on the analysis slide in your pack, residual analysis of the cohorts 1 to 9. So just important to point out, I guess, that the numbers remaining in those cohorts have the declined people taken out of the data. So we reduce the numbers if somebody's been contacted 3 times and quite categorically declined the offer of the vaccination. But you will see from that data that we still have some quite considerable numbers left in those cohorts and in those vulnerable cohorts as well, which is of concern and is obviously a priority for us to maintain as we move forward. Some of the challenge obviously with that is just the kind of complexity of managing the additional cohorts as they are opened up nationally. So we have a kind of competing set of issues in the sense that we have to maintain second doses for people who have already had the vaccine, and then that has impact on capacity to offer first doses both to the new cohorts but also to the catch-up cohorts that we still obviously are very important for us to keep focused on. So in respect of that, then I guess we just highlighting the work that we're doing on our outreach program. So in terms of the work that we've done collectively with our public health team, building on the model of community champions and working really proactively via our community and voluntary sector networks in order to promote an engagement model and then hopefully have the impact on vaccine uptake. There's some detail in the pack about where we are up to on that process. The panels to agree the grants to the individual voluntary sectors organisations met this week, Monday, Tuesday, and we hope to formally inform people by the end of this week about those grants. And therefore, you will see in the pack that we've got a number of outreach events already scheduled, dates with the Excel team supporting us from the delivery side, so that the voluntary sector organisation will do the engagement work and build that kind of demand really through their networks and through their kind of trusted engagement with their own communities. We're also looking at other ways to complement that in more depth with some other possible mobile options. So Chris Lovett in the public health team is looking into that model where we might do more of a roving model around designated settings, in particular around care homes where there may still remain staff groups that are unvaccinated. But also we have got an offer from the St John's Ambulance service, which we were told last night is they're ready now to move to our patch. So that's another mobile and outreach model that we'll be able to deploy in the coming weeks, which will also increase that visibility and that activity and hopefully encourage that more word of mouth and confidence building. Some of the other complications around that, I guess, just to highlight, are, you probably have picked this up now from the press and stuff, that the supply of vaccine around the AZ vaccine, which is more sort of portable and more conducive to outreach work, has now been quite severely impacted. And then coupled with some of the concerns about safety of that vaccine, that has meant made some of the outreach models more precarious. But just to assure you that the vaccine that we have secured that through the Excel booking, so that's in place. So we know that we have that and we can deliver that model. At North East London level, though, we're also looking into the technicalities of running a Pfizer outreach model, so we can understand how that can be deployed going forward. And then just finally, really just to draw your attention on the ongoing work that we're doing with practices. So you'll see in the data packs that you'll see there is what we call our ski slope approach to highlighting the activity at practice level. And there is a big range across practices about that uptake. And we are now doing some further communications with patients directly, offering them there are two things. One is the whole household approach. So you come with your family if that makes you more inclined to take the vaccine, and also offering the offer of the Pfizer vaccine as opposed to AstraZeneca, which we're hoping as well may also increase open up a new sort of dialogue with some of those reluctant people that remain unvaccinated in the population. So I'll pause there and take any questions, if that's okay, Mark.
Yeah, great. No, thanks, Sean. Right. Oops, let's just get the hands. Whose hand is that? Chris Kennedy.
Oh, I can't hear you, Chris.
Chris, we can't hear you. Right, I think that was hang on a moment in sign language or something.
Indeed, hang on a moment in sign language.
There we go.
A new universal sign. Good.
Yes. Thank you very much, Yvonne, and a really helpful slide deck. I'd love to know a little bit more about the transfer from the GP Confed to the PCNs.
Okay.
Because there's a little bit in there. I'm presuming that Volunteer Centre Hackney will continue coordinating the volunteers. I'm slightly worried about we're handing over to the PCNs, but it looks like from the ski slope that certainly some practices will have got their own issues, if you see what I mean. So are we also at the same time helping the practices with the lower vaccination rates to catch up, as it were?
Yes, absolutely. We are in that transition phase at the moment, so it is another complication, I guess, in terms of managing the programme. But there is an active planning group working on that on a weekly basis, well, a daily basis, but meeting formally on a weekly basis and reporting into the vaccine steering group. The timetable is around the 1st of June, and yes, we know our expectation is that from a patient perspective that should be experienced as a seamless and unnoticeable transfer of the service. I think there are other parts of the country where some PCNs are keen not to continue with the programme. There are other places where PCNs are actively continuing, and it felt very important that we continue with our local vaccination centres. And there is a challenge, obviously, because of the Pfizer vaccine. Having a centre does make that somewhat more doable. So a good decision in some ways that we're keeping both things going. The transition is, I guess, it's planning really all of the functions and all of the infrastructure that the Confederation have put in place will be what's transferred. So the volunteer centre, there's about 300 people, I think, involved in volunteers and people, on the kind of staff payroll, and all of that is what will transfer to the PCN management. The PCN directors have appointed an operations director who is actively involved in the LVSs anyway. So there's a lot of learning and building on the experience of the local and all the success that the local vaccination centres have had. But really, the opportunity to offer a more embedded, dispersed model as part of the whole offer for City and Hackney, I think, is some of the benefits we're hoping we will see as a result of the PCN ownership being more defined, and the PCN leadership as well being able to take practices on with them and review some of the way things have been done and making sure that the most effective things are being deployed, notwithstanding that the younger cohorts probably require quite a different approach. So it is a complicated picture because things change all of the time, but basically that's the plan. And Haren is on the call, so I don't know, he might want to comment from it because he's obviously one of our clinical directors, although not leading on this piece of work, that may have a view on that process.
Graham, thank you. Before I bring in, I think Jenny's got her hand up, actually. Jenny's up.
Oh, Jenny's there as well. Sorry, there's so many dots. Yeah, thank you.
Bring you in, Jenny. I forgot to remind people, this is being recorded as per usual and will be posted up on our social media channels, etc. Just to remind everyone that's the case, and it will be the case throughout the whole ICB this morning. So Jenny, do you want to come back on something that Siobhan's just been saying? And then Andrew, I see your hand is up, but I'll bring Jenny in now because I think she's probably going to speak to this point.
Hi, morning everyone. Yeah, thanks Siobhan. I mean, I'm one of the clinical directors leading with Tasinka on the actual transition of the COVID cohort groups 10 to 12, and just to confirm everything that Siobhan has said, really, we are working really closely with the Confed, and we have a transition meeting every week to kind of discuss how we make this seamless, particularly for the patients, and we don't want to lose any of the good work that has been done so far by the Confederation. I mean, it does run very, very well. It is a big task, and we do have a date of the 1st of June, and everyone is working really hard to kind of make sure that we can kind of be able to transfer everything by the 1st of June, although it's not set in stone. Our kind of the way we want to kind of do this is to try and get kind of ownership of the LVCs back to the practices through the PCNs, through the networks, through the clinical directors. And we're aware of some of the practices who perhaps might need a little bit more support, and we're taking that all into consideration. I think in some respects, we're quite lucky that the cohorts are slightly different. They're younger. We don't have the issues of the long-term conditions to kind of contend with. And most people, if they want it, will just come along for their vaccinations. And so we do want to try and do it slightly different, as well as the LVC centres. We'll consider other ways of trying to reach the population of patients that we're doing. But at the same time, we're also kind of bearing in mind that there are some people in cohorts 1 to 9 who haven't had their vaccines yet, and so we're taking on board some of the initiatives that are coming from around, such as, you know, doing the whole generation of patients for vaccines, and that's all been thrown into the model. So the idea is that actually it's not a transactional handover. It is going to be one whereby we're all kind of working together, but with the PCNs focusing on 10 to 12, but also doing 1 to 9, and the Confed doing the same.
Thanks. Andrew, shall I bring you in now?
Thank you very much. And I do acknowledge and thank you all. A lot of hard work, and this is very complicated and difficult to crack. But just a couple of questions in that context, because I've looked at the benchmarking of ourselves against NEL, and I think, Siobhan, you said it does look like we've plateaued a bit. So I'm almost wondering, what timescale do you have in mind that we should begin to see the impact of some of these measures in terms of moving us forwards, and if we have any contingency plans in place if it doesn't? And then just a general question just in relation to the data. I accept it's City and Hackney, but as you know, for the health economy across the city, we also need to be pulling in those patients who are registered with Tower Hamlets, and if there's some way that we could get the complete picture in terms of the data. Thank you.
Sure.
Yeah, so on the subsequent point, Andrew, I mean, I think we do have the data, and if you'd like to see it in the deck, then that's something I'm sure we can do, because I don't think that should be difficult for us to achieve, because it's available to us. And then I guess, yeah, I mean, it's hard to say really in terms of when we'll see an impact, because there's I guess the actual events on themselves, you'll see from the pack that some of the events we've run thus far have had potentially quite small numbers of people coming forward to be vaccinated, and potentially sometimes not always the people in those vulnerable groups. So I'm hoping that we'll see some impact from the outreach work, but I wouldn't expect it to have, a huge dramatic increase in terms of uptake, because it just, the evidence just does suggest so far that it doesn't bring in thousands of people. Having said that, and I mean, we have done exercises where we've offered walk-in, and we've tried to take out as many barriers to the access issues as possible, and contacted all of the people previously who were unvaccinated. I think it was about 18,000 people who are invited in again, and I think we had about 400 people come. So that just shows you the scale of some of the task, really. But we visit these numbers every week, so we're kind of constantly looking at them, and we will be able to see fairly rapidly about impact. And in terms of the texting and the subsequent offers of the household vaccination plus the Pfizer offer, we're definitely going to be closely monitoring that from next week in terms of feedback from practices about how many people may have been persuaded by that change in approach. So we will just have to kind of watch and wait, I think, to some extent, and see what the impact is, and then we will continue to look at other opportunities around these roving models, and particularly the kind of model of the outreach with the St John's Ambulance, etc., and whether those things will, following on behind from what we've already got planned, make any further impact.
Thanks, Siobhan. I mean, it's interesting to say about further mitigations. At the moment, it feels to me that all the further mitigations are already being brought forward.
Yes.
With this new, ongoing suite of various trials of interventions to improve the situation. I'm hearing a few clonks, obviously all get magnified, and looking down the participant list, there are about 4 people who aren't muted. So just an anonymised reminder before I call anyone out. Could you make sure you go on mute? So who's next? It's Philip Glanville.
Thanks, Mark, and thanks, Siobhan. And I echo what Andrew said in terms of both comprehensive paper and obviously all of the work that's happening, especially around the transition from the Confed to the PCN network. And obviously that is an additional challenge along with that vaccine, continued vaccine lumpiness. I just wanted to pull out 2 points, really. One, I think it's really great to see the VCS organisations and outreach dates kind of mapped, and obviously that capacity booked. That's incredibly important. Those dates, though, will come very quickly, and just making sure, I suppose, that the sooner we have a widely shared kind of matching of either communities or geography to those dates, the more we can mobilise in terms of community buy-in through all of our different comms channels. And then just exploring the point about geography, there's referenced heat maps are being looked at for door-to-door visits, and there's a paper going to the board for approval around the menu of options. I'm not at all fixated on buses and estate pop-ups, but I think we need to understand the rationale for not doing that, given so many people now are, and people obviously see that and wonder why that isn't happening. And if we've got a good narrative about why we think our existing model enhanced model will work, then obviously that's fine, but it's just articulating that. And I suppose the last bit, it does seem, if you look at the previous events, that the more open the walk-in is, the larger the numbers. Now, I appreciate the point about them not reaching some of the groups we're targeting, but that barrier thing still seems to be really important, the sort of barrier to booking, and that multi-generational point could help with that. And obviously Josephine talked about that, I think, as well. So I just wonder when you think we might be able to, is that a local decision, or is that still requiring some degree of clinical guidance from the centre? Thanks very much, Mark.
Yeah, thanks. So
the multi-generational approach is now authorised, as it were. So we've got a clear message from North East London that we can offer that. So that is available. So that will form part of the offer that primary care will offer directly to the unvaccinated cohorts in their approaches that we're going to be making over the next week. The communications piece, I spoke with Chris Lovett last night, and we are definitely ensuring that our communications offer that we have in place jointly with the council anyway. We're going to make sure that we're going to have regular meetings to plan that alongside the events as they emerge. The bus is an option for the voluntary sector organisations should they want it as part of their outreach engagement work. We have already secured Doctors of the World as a possible offer. They're willing to come along and do an event if that's what's required. So we can do, and the Greenwich bus is still in the mix as part of that programme, so it still could happen. And similarly, this St John's ambulance offer is also mobile in that sense, so it is a bus that will be deployed. I think that's the piece that we're going to be doing really now, is building on those heat maps and the intelligence that shows us from a geographical perspective about where we might want to deploy some of those additional offers that we have come online really in the last day, especially around the St John's ambulance offer. We could run that sort of slightly separate to the VCS programme, so it's another way that we can make it more visible and targeted within the geography.
Great. I bring Randall Anderson.
Thank you. Two questions. One, the rough sleeping population that we both brought in, and I know greenhouse surgery is the lowest uptake and I believe they're the one in Hackney that deals with this population, and I know we had one go at it in the city, but I believe there was supposed to be a follow-up, but I don't know that that's happened. So I was wondering what's going on with that. And then secondly, I think both local authorities had sort of offered to be involved in a bit of door knocking on something to, door knock. Here's the vaccine. Do you want it? And I don't know what's happened with that model. Thank you.
So in terms of the homeless, we have been, one of our GPs has been doing a kind of roving approach herself, with a small group of supporting her in terms of vaccine delivery into hotels and hostels and settings where people have been accommodated as part of the pandemic. So she has been doing that alongside the previous offer that was put in place through the Excel team and that follow-up work. I think there are still a lot of issues about accepting the offer from the population, but I agree with you, Randall. I think there's more we want to be doing in terms of some of our other partners around that. And Rhiannon, who's the GP lead for homelessness, is also having those conversations with colleagues in the ELFT outreach service and the NEL team as a kind of ongoing programme going forwards, really. She's done a lot of the vaccination offer personally, but that's probably not sustainable. So we need to think about how we use some of our outreach services to keep that sustainable going forwards, and that continuous offer, really, because I think that's what it's going to require. But that again will be hampered slightly by the issues about availability of certain vaccines. But the offer is obviously there for all of the greenhouse people registered to go to any of the vaccination sites, and they are often just encouraged to walk round to Bocking Street rather than book, because they will be accommodated by the service. You want to come back?
Well, just our city population is never going to.
Yeah.
Bocking.
Yeah, so I guess that will be something we will need to look at specifically around the outreach model and or pharmacy offer potentially. We've been talking quite a lot with the pharmacists about trying to find ways to do walk-ins as well, because that's quite challenging for them, and they can't do outreach work interestingly, they're not allowed to take their own vaccine to do outreach. It's just one of the rules. So they're quite keen. They are keen to do as much as they can to be make themselves as accessible as possible. So that might be something we can explore in the city in terms of some walk-in appointments. But I understand your frustration in the sense that we just need to keep making it available as much as we can.
I think it might be useful if Rhiannon had a chat with our homeless outreach.
Yeah, she is very actively involved with all those networks. So I can find out exactly what she's done in terms of city locations, if that would be helpful, because I'm sure she's probably been to some.
Yeah, thank you.
Okay.
And then on the door knocking.
Well, the door knocking is one of the next round of mitigations that we're going to try and look into doing. We've been more focused on getting the outreach program up and running, and we are looking at that as an option. We've had some success, I suppose, in thinking about people who haven't responded, and I think the city did do some work in terms of contacting people who hadn't responded to approaches, but we haven't yet managed to get round to doing the actual deployment of a team to go round and knock on people's doors. But that's the work that Chris Lovett is going to pull together for the vaccine steering group next week as a proposal.
Great, thanks, Siobhan. So we've got 3 more hands up actually, but can I take all those questions, comments collectively, and then Siobhan pick them up together because of time. So Sandra Husbands, over to you.
Yeah, thanks, Mark. Thanks, Siobhan. And these are comments really, and that I hope are helpful rather than questions. And I'll just pick up Randall's point about the door knocking to begin with, which is that was never really about taking the vaccine door to door. It was about door knocking to make contact with people that we'd failed to be able to contact by other means, and having a conversation with them, and then helping them to book if they wanted to book, etc. So it wasn't really a here's the vaccine, do you want it kind of model. But we've actually had some success on the phone, and so far haven't had to actually go door to door, but that's still kind of in our back pockets. The other comment I really wanted to make was about the fact that we have reduced the barriers enormously, but we shouldn't really underestimate the importance of persistence and patience with every group that we're looking at, not just with the homeless group, but actually all of the people who haven't come forward for vaccination so far. We have to be persistent, and we also have to be patient, as well as keeping all of the barriers low. A single opportunity, if you tell everybody about it, but that's all at one place and time, doesn't mean that it's going to be their number one priority for that day or that weekend. And so we have to keep going back with the same offer.
Grand. Okay, thanks, Sandra. Antoinette Bramble.
Thank you, Chair. Just to build on some of the points that have been said earlier this morning, really, and want to thank everyone for the work that's going on, and pleased to hear there's more sessions with the communities in play. I know that the session that Jake led with Hackney CVS was very, very positive, and at the end of the session, people said in the survey that they felt more confident after the session than before in terms of vaccinating. I've been in another session with Dr. Husbands, and again, people felt reassured. So I don't think you can underestimate the importance of having those conversations with the community. And I think the more that we can get built in, the better. I think it's really good if we have lots and we have to cancel rather than having to go through a trench then plan, because it's really going to be an ongoing thing. I mean, Dr. Husband spoke recently in the media talking about hesitation of why people have come forward, where vaccinations have been trialled in other countries and it's gone wrong. So we are trying to alleviate some real fears and concerns. And I don't know, you said that you didn't expect there to be quite an increase in the data, but I wondered when you think that some of that work, that whether it's Hackney CVS, the CCG or the council, when do you think some of that may begin to take dividends and expect an increase in the take up?
Okay, pick that up, maybe Siobhan. I'm going to give Haren the last question from you because we need to move on, I guess, after this. There are no more hands now. Haren.
Thank you, Mark. Just question for Siobhan. Now, you mentioned about the pharmacies and they're doing a good work, but it's mostly AstraZeneca. And moving towards cohort 10, 11, 12, I think we'll have to use more Pfizer. So how are they going to manage? Have you got some plan? Jenny might be able to answer this as well.
Okay.
Yeah, so, okay. Shall I respond, Mark? Yeah. So yes, Haren, there are some pharmacies that are actually already agreeing to do Pfizer and are undertaking the training. Our medicines team are supporting that work, and I can't remember now. I know that there is definitely at least 3 in Hackney, I think, that are currently doing it. But we had the update yesterday at the vaccine steering group from Yogi. And yeah, they seem very willing, quite a number of them, but some of them have made applications for approval of additional outside space, because people they have to have the waiting area for supervising people after the vaccine. But a lot of them are definitely willing to work with that vaccine. In terms of the outcomes, I guess one of the things that in terms of the outcomes of the outreach work, we have got an evaluation process in place as part of the outreach programme, and it might be helpful if we brought that back next month in terms of thinking a little bit about measuring for impact, and so we can share some of that planned work that's being coordinated by Gwynedd in the public health team, and give more of a sense of some of the impact that we'll be monitoring, if that would be helpful. I think rather than me sort of trying to answer that question, because I don't think I could say really scientifically whether when and where we might have an impact, but that might be a helpful way for the next meeting.
Yeah.
Good. Okay. Thanks, everybody. I think we probably ought to move on. As ever, a really kind of robust kind of exploration of the challenges. And Siobhan, thank you very much for sort of taking all the questions. It is really, really difficult and challenging, and it's wonderful to see so much effort going into this, but it is so important that we get as many people as we possibly can. I think we'll all agree on that endeavour, that's for sure. So let's move on to the data intelligence. Diana Divajeva, are you on? I know you're on the call. Are you ready to go? Give us some of the numbers.
Yes, ready to go.
Thank you.
Good morning, everybody. I will share my screen, and as always, you can access the same slides via our coronavirus page. Sorry, it's not letting me to paste the link for some reason. There you go now. Okay. I hope you can see my screen. Just let me know if not.
Yep.
Yes. So this is the Hackney coronavirus data page. You'll be familiar with it by now. The main good news is that in the past 2 months, so since about beginning of March, we have seen a relatively stable situation with regards to cases. Apologies, just refreshing itself. So we do see some week-on fluctuations, but the number of cases are a low week on week, and the fluctuations usually are within single digits. So if there is, say, for instance, in Hackney, there was an increase by 12%, usually it would be just a few cases that result in that increase. And equally in the City of London, the situation is really quite stable. So that's good news. With regards to how that compares across age groups, so this is not a very easy chart to read, apologies. I think we need to do something about that one, because we had such a high peak that now it masks the differences between different age groups, but I've checked that this morning and I can let you know that the highest rates are among the working age population, so this is 20 to 59-year-olds. The under 20s, they're seeing second highest incidence rates, and our 60 plus populations really low rates, only about 3 per 100,000 population, so which is really low, and that's good news. There is some variation in terms of where the cases are, but again, that changes week on. So for the last week, we can see that the incidence over 100 is, between 50 and 100 is in Hoxton and East Shoreditch and here in Woodbury Town, and there's a 25 to 50 range in Brownswood. Otherwise, across Hackney and City, the incidence rate is under 25. Again, this is very low compared to where we were back in winter. And in terms of how we compare across London, we are towards the top, but really the bottom are around 12 per 100,000 incidents, and ours is 17. So this is not very significant in terms of difference. While places like Ealing and Hounslow have almost double the rate of ours. And equally with testing, we see a relatively stable picture. So there is, again, week-on fluctuations, but they are not large. And our positivity rate, importantly, has remained really stable over the past 2 months as well. So that's the tests, of all the tests are come back positive, and it's hovering right now around 0.5, which is one of the lowest we've seen since the beginning of us collecting that statistics. We also present the vaccinations, geographic variation in vaccination rates. This is for public consumption, not for operational use. We use the public data that are available from the NHS site. And it's slightly different from the other data that we're using, the one that Siobhan has presented. There are some quirks within the data sets. Equally, where we use it for operational purposes, we tend to look at the proportion and numbers of unvaccinated, while this site is presenting the proportion vaccinated. It can be filtered into various age groups, but the overall vaccination rate, you can see there is a variation with higher rates in the City of London and around this area of Hackney. And there are some places in Hackney like Shoreditch where the vaccination rate is relatively low compared to other areas within the borough. And in the table here, you can see how the numbers of people vaccinated by a different age group has changed from the previous week. Again, apologies for just the automatic refresh. And you can see that we don't see a very large increase in those age groups that have started the vaccination program earlier on, that few months back. And the highest increases are among those that just started being vaccinated. And the last chart is on deaths. So for a few weeks there in March, we haven't seen any, and that was really good news. However, in the past 3 weeks of available data, we have seen 1 death a week for each of these weeks. So that just means that by no means we are out of the woods yet, and all the good work has to continue. It has paid off, I have to say, because we see significant impacts, for example, with our educational settings, where we were back in a day when we didn't have lateral flow testing versus now. These are just the number of cases that are absent from school and by setting. So you can see that we had really high proportion of pupils and staff being absent back in winter, and now with the lateral flow program, that has reduced significantly. So definitely all of the measures that has been implemented, they are having an impact, but just remembering that it's still a deadly virus and we do see deaths coming through. And just the last point on the NHS pressures. So for in-city and Hackney, so Homerton Hospital, we don't really see any cases. We haven't seen any cases in intensive care, which is really good news. We see about just under 1% of general and acute bed occupied by COVID patients. Again, that's the lowest we've seen for a very long time. So a significant reduction from the few months back. And that's it for a very short update.
Great, thanks, Gianna. I've got a couple of hands up. Philip Glanville.
Sorry, legacy hands, Chair.
Okay, and then Haren Patel.
Yes, Diana, very a good presentation.
Oh, yes, Haren, I think we've lost you. Okay, sorry, Haren. We'll have to wait for you to log back in. Any other? John Williams, let's go to you whilst Haren sorts out his bit of IT.
Thanks, Mark. Very good presentation. Thank you very much for the data. Just kind of because there's been some reports in the press about the Indian variants, is there any kind of concern at the moment that we are seeing any developments here? Because there sounds like there's kind of increases in southeast London, sorry, yeah, southeast England and possibly London as well. And also just to comment on the use of the phrase Indian variant, as it's pointed out to me yesterday, it's kind of we saw attacks on the Chinese community when it was being referred to as the Chinese virus. So I think we need to be careful about the language we use around that as well, just to make sure we don't see hate crimes against people from India as well, if this does take off. Thanks.
Sandra,
Diane, do you want me to respond? Or?
Yeah, well,
okay.
I'm not sure how much detail I can reveal.
Okay. But, well, thanks, Diana. I'll take it. First of all, John, thanks for the question, and also thank you for the point about how we designate these different variants. They actually do all have names. The names are all sort of, letters and numbers, and that makes them hard for people to remember. And so, and I'm not saying that this is an excuse, but I think it's one of the reasons that people have been doing things like, say, calling it the Kent variant or the South African variant, or whatever, or as in the European Union, they call the one that we call the Kent variant, they call that the UK variant, for instance, but they actually all do have names. And I try to refer to them by their names, but then I usually then have to also make the say that the one, that was the so-called Indian variant, because otherwise people don't know what I'm talking about in large part. So the two that we're particularly concerned about are B1.351, which is the one that was first identified in South Africa. There are 3 that have been identified in India, three variants that were variants under investigation in this country. And now one of them has been designated also as a variant of concern, and that's B1.617.2. There's also 0.1 and 0.3, which are still under investigation, and it's the 0.2 one that seems to be spreading more rapidly in India and elsewhere than the other 2. And there have been a number of cases and clusters of that identified in this country. And I can say that across London and locally, there have been cases of both the B1351 and B1617.2 identified, but there's not very much I can tell you about it at the moment.
And I guess that where those are sometimes seen, we talk about surge testing, etc. And I know there are no plans for surge testing in our area at the moment. Is that correct, Sandra?
Yeah, that is correct, that we don't have plans to do surge testing.
Oh, yeah. Okay, Haren, you're back with us. Do you want to ask?
Yes,
I think we'll give you the last question before I hand back to Sandra.
Yeah, it was a technical problem. So, Diana, very nice presentation, but it was very informative to us. Now, I see in one of your graphs, there's an increase in number of cases around Dalston, Hackney, Wick, and Homerton. So, it's a solid patch there. Do we deep dive and find why?
Which chart are you referring to? Is that the
one of the
ward,
it shows locality-wise rises and where they are going down? The cases, I think, second or third slide. Yeah.
I think it's the map of, the ward map of cases, or MSOA's
yes.
cases.
Right. So if it's the ward map, then around Hoxton in the last week, there were just 9 cases, really. So it does say weekly cases, 9. And in Woodbury Down, weekly cases, there were 6 cases. So it just looks quite dramatic compared to the rest of the borough because it's all in pale blue, and that one is quite dark. We have not seen any big residential outbreaks. we had some outbreaks in institutions, but we have not yet seen anything huge in terms of just residential properties among the residents. But definitely, teams who are working on testing and vaccination, they are using these statistics to plan for where to put, for instance, pop-up clinics or vaccination centers, or where to target the comms. So that information is being used whenever we see, for instance, some areas are a bit more reluctant to vaccinate versus others. So the more effort will be put into those areas where we see more cases, then more effort around testing will be put into those areas. So those statistics always used in terms of actions, if that's reassuring.
Thank you.
Good. Thanks, Jenna. And I think we'd better move on. I think, John, that's a legacy hand, is it? Oh, it's gone. Yeah. Oh, no, it hasn't gone. Is it not a legacy hand?
It's gone.
It's gone. Great. OK, so let's move on because time is galloping on. So, Jenna, thanks for that. Sandra, do you want to give us a brief update of anything from the local control plan?
Yes, thanks, Mark. And first of all, apologies to everyone that the paper came out so late that it somehow got lost in the ether. And so Alex wasn't able to locate it and then forward it to all of you. So as a consequence, I will briefly summarize some of the key points, but I won't go through it all because it's actually quite long. So the key things I wanted to point out are that we've had continued to increase our capacity for local testing, including what's the word? Standing up the test sites for community collect, and also pharmacies, so that people are able to collect boxes of lateral flow devices so they can do home testing twice a week. And last month, the lateral flow test, asymptomatic test management was transferred from the previous provider to a new organisation called IF Crew, who came in and stood up some things really quickly over the Easter weekend, have very successfully taken that on and have been working very closely with us on some of the key issues that we've had over the past few weeks. We've also implemented our COVID response team in Hackney, which is primarily from environmental health staff, but working very closely with public health under the leadership of Andrew Trathen, who's one of our public health consultants, and they've actually done an enormous amount of work already with local businesses, and in particular where we've had situations occur in those businesses, they've been able to go out and visit and support them, not just reviewing risk assessments on paper, but actually going out to the premises and seeing that all of the things that they say that they have in place are actually working in practice and providing further support. And that's working in tandem with our outbreak investigation and rapid response, which Deanna mentioned, where we are that's data and intelligence, working together with contact tracing, drawing together all the different sources of data and reviewing them daily. And actually, by doing so, they've been able to identify an outbreak, a small outbreak on the premises before LCRC even picked it up and notified us. So this is a very forward thinking way of working, and it's really working well for us locally so far. And the last thing I wanted to draw your attention to was our enhanced isolation support program, which we're piloting at the moment in 2 areas of Hackney, but hope to be able to extend as we learn from it. And that's really to provide increased access to support that will help people to self-isolate where they may have difficulty, for instance, if they live in high density housing, such as an HMO. And I'll leave it there.
Great. OK, thanks, Sandra. That's very helpful indeed. Ms. Kennedy, you've got your hand up.
Thanks, brilliant to hear about the enhanced isolation work and the local contact tracing. Really positive. I just wanted to check up when you collect or get sent home now with your secondary school aged child, your lateral flow device testing. It says on the back of the packs, not for resale, as if at any point that might come into play. And I just want reassurance to be given that there are no plans to stop issuing free lateral flow device tests to individuals, especially as the business sign up stopped on April the 12th. Thanks.
So we don't have any clarity on what's going to happen beyond the end of June. So as far as we know, everything is funded and the distribution is going to continue, and all of our local distribution is going to continue at least up until the end of June. Beyond that isn't clear at all. And we, as you, are seeking further clarification. And I think that I'm not sure that at national level they've quite got the plan yet about what further measures they want to continue once everything's opened up.
Okay, great. Thank you, Sandra. I can't see any more hands, and it's just about 5:02 now. So we usually have a pause between this and the next part of the meeting. So I think we should probably wrap up the Outbreak Board at that point. Just to highlight for anyone who hasn't seen the chat, some very interesting further discussion about management of people who are unregistered population in terms of receiving vaccinations. So just it's some interesting stuff between Honor and Siobhan and Chris there. So I think probably we should reconvene. We usually give ourselves 10 minutes. I think we have got time on the second half agenda to be able to indulge ourselves for the extra 5 minutes. So shall we see each other once again at 10:05? Okay, see you then.
Hi, Mark.
Hello, Sunil. How are you?
Yeah, good. Hi, Sue. How are you? Anne.
Hello, Sunil.
Hi, everyone.
Hi.
How are you?
Very well. How are you all?
Yeah, good.
Yes, I've heard just before we start the meeting formally, I guess, that there's a problem with John from Renacy. It looks like he won't be able to join us. So, Charlotte, are you here from the lawyers?
Yes,
Super.
here from Brown Jacobson with my colleague Steve as well.
Great, because Jonathan McShane's, you're right, Jonathan, you're here. So we might need after. It looks like you'll just do a brief summary of the anchor work, Jonathan.
Very
We'll
brief,
go to the tours. Yeah, fine. I got that email as we had the other part of the meeting was seeing that kind of stuff coming in. Good. Okay, so we'll turn to that a bit earlier than planned, but that sounds good. So just whilst everyone's coming back and joining us again.
Mark, just to let you know, I've invited Rachel, who's come along to help answer any questions around some of the financial governance work we've done, in addition to myself, if questions should arise.
Yeah, yes, good. Well, at the beginning of that tour review, I'll turn to you just to do that financial context, a few minutes, and then I'll turn from you to Jonathan to introduce Charlotte and her colleagues. Good. All right. So that's a bit of orchestrating. So welcome back, everyone. Hopefully relieved and refreshed and ready to go again. So welcome to the second part of the joint ICB meeting this morning. Actually, everyone's here, so I know we're quorate. That's good. So we'll do introductions. We have some obviously colleagues visiting us to help with our discussions. So it will be helpful to introduce ourselves as we give questions as we go along, but I don't propose to do anything more formally at the beginning. So apologies. Alex, do we have any others to note now?
Sorry, no other apologies.
Okay, super, thanks. Right, so declaration of interests. We've got the register. Does anyone want to declare anything in addition in relation to today's agenda? No. Okay, so I haven't got any questions in advance from the public. As ever, I'll endeavour to take questions if we can as the conversation flows, time permitting, after the members of the committee and regular attendees have had a chance to speak. So minutes of previous meeting. Any comments or matters directly arising from those that aren't covered elsewhere? No, can't see any hands. I've got one hand. Andrew Carter.
Thank you. Difficulties unmuting, getting the camera to come on. I just wanted to confirm, just in terms of the question that you had previously from the member of the public at the last meeting, I do believe maybe Siobhan can confirm that a response was provided.
Yes, because in fact, is that relation? I did have one comment about the minutes, which was on minute 3.5, and it just says the response was as follows, and then there's a blank, isn't there, in the minutes? Is that presumably
that's probably an error with version control on the minutes, which I have to apologise for, because there was a response provided. Yes, you're right.
Okay, so that's your point as well, is it, Andrew?
It is. Yeah. Because so, we rarely get questions from the public. It would just be nice to show that we do respond to them. Although I do think there's some supplementary questions that has come from that member of the public as well.
Okay.
They may not have reached you yet, Mark.
Okay. So Alex, can we make sure that the final minutes has the blank?
Yeah, I'll make sure that gets around to everyone.
I'm not sure that we necessarily need to see the formal response at this stage. If anybody wants to, they'll contact you directly, I guess. And then you can forward them to them, but make sure the final version hasn't been. Good. Okay, so regarding, I'll just go straight to the action log, and then I'll do the sort of the agreement bit in a moment. So we've got on the actions, if I just scroll through to my papers, sorry about that. A few things are in progress or are on the forward planner. Certainly. You can see some are due for June. One of those June dates actually is now July. There's an action for Sunil noted here, which was that he would meet with Heren, which really isn't an action that the board needs to keep an eye on. I don't think it should be an action on the tracker. It's a conversation they're having outside of the meeting that we have many discussions between ourselves outside meetings, and so I don't think we need to formally note that as a committee, but I'm sure Sunil and Heren will have their conversation. And then the last one is that Sunil, which is due or May, is closed because it was going to send some information through to Helen. And so that's closed in itself. Alex, I know we spoke about whether we should keep those ones which are on the forward planner open. I think we should, because the tracker is looking pretty clean at the moment anyway. So those ones for June and July will just keep on the tracker until they actually come onto the agenda.
Yeah, sure.
Thank you. Any comments, Sunil? Yes.
Mark, just to say that the analysis for Helen has been prepared. It just needs to go out. So my apologies for the delay. I'll make sure that goes out today, and I'm quite happy to meet with Helen to talk through how the CCG delivered its year-end position of break-even in support of delivering its statutory duties and the wider system control total.
Okay. Fine. Are we content? And Helen, you're content with what I did with your noting your discussion with Sunil? I'm sure you'll have outside the meeting. I'll take that as yes. I think you might have frozen though. But anyway, I'm sure you'll put something in the chat if you're not content with that. So going back, can I ask City ICB to approve the minutes? A few nods and yeses. And City ICB to approve the minutes.
Hackney, yes.
Sorry, I said City twice in time. And Hackney as well. Thank you very much, Chris. And then going on, can I ask City ICB to note the action log? Yeah, a few nods and thank yous. And then can I ask the Hackney ICB to note the action log?
Noted.
Yeah. Thank you very much, everybody. So, right, moving on then. So, Jonathan Shane, do you want to just introduce the Anchor Alliance update piece? I know that it's going to be slightly different to what we anticipated, but you'll tell us why in a second.
Yes, so John has had a family emergency this morning, so at short notice wasn't able to come. He's very apologetic about that, but can't be helped. So Renacy have been supporting the partnership on Anchor's work for a couple of years now, and obviously a lot of that work has been made difficult by COVID, but they've still been making some good progress. There are some interesting opportunities they've identified around an apprenticeship idea, and there are some specific procurement opportunities coming up where they think there are some interesting approaches that we could take as a partnership. But John can tell us a bit more about that at the next meeting. One of the asks that John was going to make today was around partner organisations nominating a senior manager to be their point person on all of the Anchor work, because I think different people have come along to different sessions, and when they have an idea or they need a decision or a view as to whether one of the partners is committed to a particular piece of work, they're finding that quite tricky. So I think it'd be helpful if people thought about that in advance of him coming to our next meeting. And the final thing I wanted to point out is that any of you who are involved at a NEL level should be aware that there's a North East London Anchors Charter which partners have signed up to. So it's quite high level. It has principles around access to employment, procurement for social value, use of land and buildings, and the environmental impact of our work. So as I say, it's really good stuff. It's high level. Marie Gabriel is very keen on this, and I think is going to be chairing one of the boards that oversees that work. So we're going to be meeting with NEL colleagues just to make sure that our work is aligned with what they're doing. My sense is that they're going to be about developing principles and sharing best practice, but the practical work in terms of using our position as anchors within our communities is going to rest at a system, or in our case, or a borough level in other parts of North East London. But I'll be able to update in those conversations when John comes to the meeting next month.
Okay, thank you, Jonathan. I can't see any immediate. Yes, I have. I've got Jake Ferguson's hands just popped. Thank you, Jake.
Thanks, Mark. It's always nice to have your full name quoted.
Well, I should again remind everyone we are being recorded, and we will be on the meeting will be posted up on I think our YouTube channel, or anyway, as we know, it gets posted in the usual places.
It's YouTube.
Thank you, Alex.
Thanks, Mark. To our TV viewers, hi, I'm Jake Ferguson, Hackney CVA. Jonathan, it's really exciting that there's potentially a sort of partnership wide apprenticeship approach. Do you know if those who are outside the immediate named anchors can help promote that programme when it's available?
Absolutely. I know John's sense is that anchors are generally not-for-profit organisations rather than public sector organisations specifically. And the clue's in the name. It's kind of organisations that have been here for a long time and are likely to endure. Or international evidence suggests they're the most successful anchor institutions in terms of this sort of work, and clearly HCVS and a number of the organisations that are members of HCVS would fall into those categories. So I'll make sure that if you come up with a name, whether it's yourself or someone else, to be the point person for John, then we can make sure that HCVS are closely involved in the work.
Right, it can be me in the first instance, Jonathan.
Okay, thank you.
Thank you.
Grand. Right, just acknowledging a few people in the chat will have to leave the meeting early, but so Honor, over to you.
Thank you, and I'm Honor Rhodes for posterity. I was really intrigued that the notion of public and patient engagement is not high on the agenda here. It seems, I understand, but I'm sad given that we have a co-production charter here. And I would have thought that it isn't just about the public perception of our anchor organisations, it's about how the public and users would like our anchor organisations to develop and grow. So I would just like a little bit more thought about that, please.
Okay, I'm happy to feed that back, and I think you're entirely right.
Okay, Sandra Husbands.
Yeah, thanks, Mark, and thanks, Jonathan. Actually, Honor just articulated something I was thinking, and sort of building on what she said, I was thinking about the in the context of the NEL Charter as well, that there's something missing around adding social value, which is not just about jobs and training. And I'm wondering how we build that into what we're doing locally in City and Hackney.
So I think that the Charter does talk about procurement and how you introduce concepts around social value into your decision making around procurement. So I think one of the best things we could do there is learn from partners who've done a lot of work in this area. I know London Borough of Hackney, and I'm sure the City and others have done a lot of work, because obviously procurement is very technical and you can be subject to challenge if you don't get it right. But there are ways of trying to achieve these wider objectives whilst keeping in line with procurement rules. So I think there's some really good practice that can be shared amongst partners. But you're right, it should be made more prominent.
Yeah, thanks, Jonathan. But I also meant that there's something beyond that, which is about who we are as organisations and how we interact with the community around us, who may not actually apply for jobs, and we may not procure anything from them, but they may still derive value from us being anchors in the community. And what does that mean, and how do we embody that?
Okay.
Excellent. Okay, so thank you, Sandra. So, Jonathan, so quite a few useful comments to take back. Sunil, did you? Yes, your hand's come up.
Thank you, Mark. I'm Sunil Thacker, Director of Finance for NEL. Jonathan, just really interested in that procurement point within the documentation, because within the NEL CCG, and as part of our financial governance program, we've established a procurement committee that leads on looking at all of our contractual arrangements on a year-to-go basis and looks to renew or recalibrate or consider the direction of travel of those contracts. So I'm quite keen to understand this program of work relative to ours and see how we can sort of integrate and add value in the way it's described in some places within this paper. So I think I would like to sort of meet with you and our local team within financial governance to talk about this in some more detail, please. That's okay.
Yeah, that's fine. And for people who haven't seen it, I'll circulate shortly the NEL Charter, because in terms of that procurement for social value, it does go into quite a lot of detail. And inevitably, the challenge with this sort of charter is, people come along to a meeting and it sounds positive and they sign up to it in principle, but then the practice doesn't follow. So I think getting involved in the sort of work you're describing, Sunil, feels crucial if we're going to turn those aspirations into a practical difference in terms of how we work.
Okay, thanks, Jonathan. Well, actually, a really good conversation, actually, but bearing in mind that the principal speaker isn't with us. So, but lots of, and also in the chat as well. So comments, Jonathan, thanks for circulating that. And I'm sure you need to share all of what we've just aired here with John before he comes next time. So thank you for that. Should we move on? Yeah, sorry, I've just a comment made me laugh. So let's move on to our update on the terms of reference for our ICPB. I think I wanted to ask Sunil initially to set a bit of context for just to remind us of a sort of reality check, because we have the area subcommittee of the North East London CCG, to which will be delegated the majority of the financial resources that previously sat with the CCG before we were a single CCG, when we were a City and Hackney CCG. But I think the context and reality check of what that means in terms of how that money is spent in the operating plan, and just give us a kind of check about actually how we have to operate, the rules we have to operate within. And actually that then gives us a firm footing, I think, at this point to then start to develop our aspirations moving into the future around how we use money within the system in different ways to support our ambitions around greater integration and all the rest. So Sunil, do you want to give us a 2 or 3 minute contextual update? Then I'm going to turn to Jonathan to introduce our lawyers to do their presentation on the tour. So Sunil, over to you.
Thank you, Mark. And what I'll do is I may bring Rachel, who's my financial governance lead, into this conversation as well. Then I'll give everyone a situation update of where we landed in terms of the NEL merger. So essentially, the merger, I would say, has happened. It's successful. We're operating as an LCCG. In terms of the financial governance program that I led on for the NEL CCG over the last several months, that included essentially the standing up of SFIs, standing financial instructions, and scheme of delegation and reservation for the new organisation that is fit for purpose for NEL CCG, but allows us to operate within the 3 ICP arrangement. And we work very closely with Charlotte and her team, the firm of lawyers representing us, to actually stand up those arrangements, and also in pulling together the Finance and Performance Committee NEL terms of reference and the subcommittee terms of reference. So essentially what I'm saying to everyone is that I think we're in a fit for purpose state in allowing us to conduct our business going forward. We have a framework which allows us to do so. But in addition to the SFIs and the SWORD, we've also statutorily transferred all of the contracts across the 7 CCGs into the new NEL organisation, but not just the contracts and the financial commitments. And for the legacy City and Hackney CCG organisation, that means the £500 million worth of financial arrangements and commitments essentially have been rolled forward into the NEL CCG. So for City and Hackney ICP, as part of our ongoing operating plan programme of work, which is nearing completion, we probably have just over £500 million worth of financial commitments to take forward as an organisation. In addition to that, that funding that's coming down to us, we have service development funding, which is recurrent type funding for transformation, which will be devolved down to ICPs. There will be COVID support funding, which again the ICP will use to drive forward its vaccination type programs, and there'll be other initiatives which come our way. So still a £500 million operation, contracts transferred over, likewise commitments, SFIs and SWORD in place to allow us to carry on our business. From an internal external audit perspective, those programs are in place and have been signed off by the appropriate committees. From a Section 75 perspective, all of the Section 75 arrangements across the 7 CCGs, the 3 ICPs in the main, are all in place and will continue to be reviewed and worked on a year-to-go basis. I'll stop there. There's a lot of information. Happy to take questions, and I hope that gives committee members and attendees assurance that we start this new financial year in a good place. And later on during the finance update, I will cover off year end and the operating plan piece relating to City and Hackney ICP and the NEL CCG.
Great, thanks, Sonal. Haren, you've got your hand up.
Wondering whether he's frozen or something's happened to his connection.
Yes, I was having a few IT problems because he's froze before.
So City and Hackney has a long history of innovation, new ideas, implementing new changes, and always have applied and secured funding for that. So in a new kind of a NEL level, I know you keep on saying 80-20, but if would there be a problem if they say, well, is equity for all and leveling up and it will hinder our innovation? Do you think that will be a risk?
It's a really good question, Haren. Let me break that down and let me give you some background. We have submitted the NEL operating plan to our regulator, and City and Hackney ICP's budget is around £505 million, which is consistent with previous years. It makes all of the assumptions from the old City and Hackney CCG organisations in terms of our ambition to continue to drive innovation. But we need to be mindful that there will be cost pressures around restart and recovery, COVID vaccination, workforce issues, CHC prescribing, and all of these things, will have to be dealt with on a year-to-go basis. As I said earlier on, there is service development funding which is available to NEL CCG, and that funding will make its way down to ICPs. And yes, that funding still needs to be disaggregated in a way that's fair and equitable. So conversations are being had by the 3 ICPs in how that money is being chunked up. It may be on a weighted population basis, it may be on an unweighted population basis, it may be on the basis of how those services in the respective ICPs have developed and where those services need more funding to actually bring them back up to a certain level that's fair and equitable. And those conversations are still taking place. And for City and Hackney ICP, I suppose what I'm saying is we are starting off from a good platform. And in addition to our operating structure, you recall that David Mayer previously spoke about strategic enablers and how the CCG had provided some financial resource to allow those enablers to do the good work we continue to do going forward. So it's underpinned by some funding as well. So I think we can continue our innovation programs. And I'm also mindful that with my TNW hat on as their DOF, there is some levelling up to be done there, but I also recognise levelling up can't be done overnight. It needs to be a gradual process, looking at the facts and detail relative to what funding we have available and how we can work as system partners. So it is work in progress going forward, and I'm quite happy to discuss this with you in some more detail outside of this meeting. It is complex, and there are imbalances and inequalities across the system that we need to address. It won't happen overnight, but we will work towards that. And that's certainly with my finance hat, and I'm sure colleagues around the table will do the same.
Thank you.
So thanks very much. I see Henry Black. Henry, do you want to come in at this point?
Yeah, thanks, Mark. It's just really to kind of reiterate and support what Sunil was saying. And I think, Haren makes a very, very important point, but I guess the kind of narrative is about levelling up, not levelling down, and the key principle there is that there is no intention to be raiding anybody's coffers or doing anything that would risk the kind of the good work that's being done anywhere. So when we merged the CCG, we made two kind of key kind of pledges, which were, first of which was that historic levels of allocation would be maintained, and the borough partnership budgets would track those allocations. And then the second one was that the new long-term plan money that comes through, which is substantial amounts of money, would be used to target specific areas of health inequality. And it's by doing that we enable to have that kind of twin track where we ensure that existing good practice is continued to be resourced, but we only use new money that's coming into the system to identify areas where that kind of improvement can learn from the best, and that's by that way we level up by ensuring that nowhere is kind of is at risk of being kind of disadvantaged.
Thank you.
Good, thanks, Henry. Thank you to you too, Sul. I think that's very clear and reassuring from and sets it out where we are at the moment and from where we then work from going into the future. And with that in mind, Jonathan, can I turn to you then to start to talk about how the governance it's got right to allow us to get on with this work safely and properly, and then we can get on with the work, as it were. So let's get the tour sorted now. So today we said we'd have a good old go at reviewing it, and with a view to lots of feedback, and with a view to trying to sign it. Well, with a view to signing it off at our June meeting. So this is preemptive and planning for that. So Jonathan, do you want to introduce your colleagues and take it from here? I know we've got quite a lot of time for discussion as well, so we have a good 10-15 minutes if you need it to present, but otherwise keen to have as much time as possible to discuss things.
Thank you, Mark. And one of the reasons that we would look to approve it at the next meeting, not today, is that partners are due to meet shortly to review the draft terms of reference for the Neighbourhood Health and Care Board. And I think we always felt that when we were going to approve the terms of reference, it would be important to do them together because of the interaction between the two. It's just been difficult finding diary slots for the people involved in Neighbourhood Health and Care Board, but that will take place in time for the June meeting. Sorry, apologies for my cuckoo clock. So Steve and Charlotte are here. They can give us an update on feedback that they've had from, in particular, from the lawyers at the City of London and the London Borough of Hackney. So there's been quite a lot of toing and froing to ensure that what we are trying to achieve here with our terms of reference sit well with some of the legal requirements on local authorities. And I think we've made some good progress, but Steve and Charlotte can update us on that. And then, as you say, Mark, great to get feedback today, but also over the next week or so, if people have any further feedback, if they can send that to me, then I can share it with Steve and Charlotte, so we're in the best place possible for the June meeting. And I guess the final thing I wanted to say was that obviously with the legislation that's going to go through Parliament to set up ICSs as statutory bodies, and these are inevitably going to be interim arrangements that are going to have to change to reflect wherever we land on ICSs. So we would want to retain as much that is good from what we're setting out here, but we've also always committed to doing a review of our new governance. I think we always indicated that we were about 6 months in, and that would sit quite nicely with the timing in terms of making any changes to prepare for ICS. So I think just go into this this new way of working as ICPB with an open mind to changes we might make, both to respond to ICS, but also to reflect on how this has worked. So how this new way of working satisfies the principles that are very important to us around democratic accountability, patient and public involvement, clinical leadership, but governance that is also designed in a way that is efficient, allows us to get business done, and supports staff to deliver real change. So we've always talked about this review, but I think it's important that we go into any review in 6 months with an open mind in terms of the changes we might need to make. But with that, I'll hand over to Steve and Charlotte, who are going to talk through the terms of reference and answer any questions that you have. I think in particular, people have been concerned about, because our arrangements are relatively complicated by incorporating the area committee and ICB into the ICPB, how that would work practically and what we would do, for instance, if there was a decision that was only for the area committee or only for ICB. So hopefully they can clear up any confusion in those areas, as well as giving an overview of the terms of reference. So over to you, Steve and Charlotte.
Thanks, Jonathan. So I'm quite keen to make this as interactive as possible and to answer your questions. So please do ask questions through the chat box or pop your hand up. So I'm not going to spend a huge amount of time going back through the sort of history about how we've got to where we are, but very briefly, we have a situation for the rest of this year where we're blending the policy objectives of integration and integrated care systems with the existing legal frameworks that we have. And those two don't always sit comfortably together. And so we have to make a few sort of careful decisions around how we enable integration while ensuring that the statutory bodies can continue to safely discharge their statutory functions. And so that's why the arrangements are not quite as streamlined as ideally we would like. And obviously post 1 April 2022, all going well, you'll be able to have slightly simpler arrangements and it won't involve some of the workarounds that we have in the tool currently. But really, hopefully, the ICPB will actually feel in many ways like a continuation of what you're currently doing. And actually listening to you this morning, I do think that that really will be the case, and that you will find that hopefully in practice the difference is relatively minor. The key difference, I suppose, is that you're moving from something that is more focused around integrated commissioning, the clue is in the title, to a more holistic integrated approach where you've got commissioners and providers, but also other representatives from the voluntary sector coming together to have discussions and to deliberate on proposals and strategy for the ICP. But you are still ultimately, when a legal decision is required, that's where you need to ensure that you've got the appropriate decision maker making the decision. And I'll come back to the staging of the meetings and how you do that safely in a moment. But that's really what the ICPB is designed to be. It's designed to enable that collaborative discussion and development of proposals, with decisions being taken within that forum as much as possible by the statutory bodies. So it's very much like a committees in common approach, except that obviously the ICPB is not a committee. But if you think of it in that way, that's what we're trying to do. We're trying to bring different parts of the system together and enabling you to work in a fairly aligned way. I think in terms of how you make the meetings work, it is, I'm afraid, a little bit probably what you'd say is a lawyer's answer, but it's around meeting planning and agenda setting. And that is really the key to making the meetings run well, because what you need to be doing when you're planning your meetings is thinking, what are we discussing at the next meeting? What decisions need to be taken, and who has a formal role in taking those decisions? And at what point in the meeting will those decisions be taken? And as part of that, one of the key sort of aspects in broadening out the scope of the membership is that you will need to be more careful around conflicts of interest. And that's the point that people get particularly concerned about. And, you know, as a lawyer, it is what I would say you do need to be mindful of for the rest of this year, because there has been no change in the statutory framework as it applies to conflicts of interest. And both the CCG and the local authorities need to be careful that they're not compromising their decision making by having people in the room who have an inappropriate interest. And so that's where you just need to be really careful about that planning and that agenda setting, and really understanding what there is about the decisions that you're going to be taken and who can appropriately be present for those. And then that goes into the staging. So as I said, ideally, the idea is that the ICPB will meet, will discuss the matters that are on the agenda, and the decisions will really be taken by the relevant decision maker at the time. So, you know, Mark, very much as you chaired it earlier when you asked for the minutes to be approved by the respective bodies, you know, where you've got a decision that you were taking, you would have the discussion and then come on to the formal decision, and you would ask the relevant decision maker to confirm whether they were making the decision or not. But in order to enable that to work well, as I said, you need to have that really careful planning and that agenda setting, and really clear understanding of what the decision is and who is lawfully required to take that. And then also in the minutes, whoever's taking the minutes needs to be really sort of aware and understand what it is that they're recording, so that that is clear as well in the minutes. I thought it might be helpful to use an example which Steve very helpfully found for me in one of your earlier meetings, just to try and bring it to life a bit, because I know it's a little bit abstract. So you discussed a pathway homeless hospital discharge team in December 2020. So having a think about how that might change. So I suppose the key difference is that in the ICPB setting, you would have the discussion around the proposal and developing this option within the ICPB, subject to ensuring that anyone with a conflict was not inappropriately part of those discussions. And then when it came to the report, that could be presented to the ICPB as well, and you would have a discussion about how you were going to take that forward. And then very much as happened, you would then say, okay, so what do we actually need to legally decide in order to approve that proposal? And so in that particular case, that involved the use of Section 75 funding. And so therefore you would need the relevant decision makers, the CCG and the local authority, to approve the decision to commit that funding in order to enable the proposal to take effect. So as I said, really, hopefully the difference will be relatively minor, and you'll actually find that it's very much as you've been operating, but with a slight shift around the terminology and a shift away from it being commissioner focused integration to broader working. So as Jonathan has said, we have worked very closely with the legal teams from both local authorities, and we've incorporated a lot of the feedback that we've had to try and make the terms of reference as clear as possible. They are quite lengthy, and they're not, you know, as I said, they're not as simple as in an ideal world we would like. They're divided into two parts. The first part governs the ICPB, and the second part includes the statutory specific arrangements that have been established. So that is the CCG area committee and the two local authority subcommittees. So the idea of having the two parts is to make sure that it's clear what parts have been established and what they are legally able to do. And when you look at what the role of the ICPB is, arguably it has no decision-making role because it's not a statutory body, but we've tried to describe it as having some policy decisions essentially around the partnership strategy and vision, and to start to lay the foundation for what the future will be in terms of once you've moved towards a statutory ICS. I might pause there and see if anybody's got any questions before I continue. I'm just trying to see the chat box.
We've got a few hands popping up. I've got a comment myself, but I'm going to be magnanimous and hand over to Randall first. Randall Anderson.
Oh, well, thank you, Mark.
You're welcome.
Yeah,
I'll get in later, don't worry.
I'll keep that in mind for the future. I suppose, in a sense, the question I had is a follow-on to much of what you've just been discussing. Clearly, some of the topics we'll be taking up will be CCG funds. Some of the topics will be ICB funds. The terms of reference contains these sort of somewhat vague phrases like 4.2 point, which one is this? 3 with delegated financial allocations and promote financial sustainability. And then in 5.1.7, it refers to ICP financial resources. And one assumes that, you know, this all comes as some sort of delegation in a formal sense from the NEL ICS or from the one CCG. But it seems to me that it would probably be quite helpful to have some more clarity around that. And I suppose maybe that's in the NEL terms of reference or the CCG. I'm not sure where it sits, but I think as long as we're having to be incredibly careful and clear on which budget we're trying to influence or decide upon, we need to have clarity as to where that comes from. Thanks.
Sunil, yes, Sunil, I don't know if you want to contribute to this one as well. So in terms of what the ICP financial role is, so I guess going back to the basic position that ICP is not a statutory body, it has no official legal status. So it brings together, much like the ICS, various funding possible streams. So we have ICS funding, which comes to the ICS. So for example, transformation funding, which goes direct to the ICS and which might be allocated to an ICP. We also have the CCG, and we have the local authority funding, which can be committed through the Section 75 arrangements. So talking about an ICP budget or an ICP delegation is somewhat inaccurate, but it's there to convey the sense that the idea is that you come together and you integrate your operation and you integrate your understanding of what funds are available so that you can appropriately progress your integrated plans and priorities and objectives. But Sunil is definitely the finance expert, not me. So Sunil, you might be able to better comment on that.
I think you've articulated it very well, Charlotte. You know, the Finance and Performance Subcommittee, the ICP, will look at, you know, we'll look at the finance programs for change or investment, but at an ICP level, you know, the budgets will be devolved down to the ICP. A lot of those budgets will be business as usual type arrangements. We will receive service development funding for programs of spend that will be decided upon by the local, through the local governance structure, the operating model, and we will have influence on the wider programs of work across North East London through the way we work. So, and the FPC has already been stood up at a local level to consider some of these issues already. Don't know whether that adds or confuses people.
One thing which I take reassurance from is that on behalf, I know Henry Black's had to leave to the meeting centre. Apologies, he had to leave at 10:30. But also, Sonal, you with obviously Rachel Tomlinson have been leading on this for the NEL for all the ICPs in terms of relationships. But it's just that the City of Hackney, we're a little bit further ahead. Yes. So in terms of the SFIs and the scheme of delegation reservation, etc., all of that work, which I guess Randall maybe wants to see more sight of, is work which has been happening. Randall.
I mean, more sight of would be helpful, I think, but I guess what I'm saying is, particularly for this transition period, it seems to me that it would probably be very helpful to have some fairly clear language around what those are and which decision-making actual bodies have to make which decisions. I mean, I think we all generally know it, but it sort of seems to me that it ought to be written down on paper so that not only do we know it, but people who read it know it.
Yeah. Sure. And actually, Randall, that's a point I probably should have explained, is that obviously these TOR do not sit in isolation. So this is one part of the structure. And actually, you then also have the Neighbourhood Health and Care Board and the finance parts of the ICP. And actually, what then needs to happen is that those need to come together. Now, we refer to that at Brown Jacobson as what we recommend is having a manual for your ICP. And the manual, the purpose of the manual is to explain in layman's terms how the system, the ICP system as a total works, how the various bits come together. Because I do understand when you read it in, in isolation, it doesn't always explain it fully. And actually, there are ways that you might describe it in the manual, which you might not necessarily want to describe in the TOR, because it's not always the simplest way to explain it. And so having it in a more practical manual that is a user guide effectively to how the ICP operates is what I would tend to suggest is the most helpful way of having that overall picture.
Will we have all of that for June?
You have the constituent parts. So once the Neighbourhood Health and Care Board TOR has been significantly enough progressed, and Jonathan, you know more than I do about where that has got to, then you would be able to write the manual, and it wouldn't need to be a very long document. It just needs to be enough to help everybody who's operating within the ICP understand how those bits come together. I don't see why that couldn't be done for June.
Okay, thank you.
Thanks very much. Okay, and Jonathan's nodding too, which is okay. So I think that sets out an expectation for what we expect to see in June. Great. So Haran Patel.
Yes, thank you, Mark, and thank you, Charlotte and Jonathan. It's a very helpful draft. I have got a comment on the main draft of terms of reference of ICPPB. I feel that it's slightly thin on clinical leadership. We have to make it more kind of clinical or more meaningful and relevant to drive the whole agenda forward. So there are various ideas I've got, but I think I can discuss that outside this meeting. But this is the point I want to make.
Yeah, very happy. If you send them to Jonathan, Jonathan will share them with us, and we can incorporate that. I agree, it's a really important point.
Thank you.
Okay, thanks, Chris Kennedy.
Thank you. I want to build on a comment that Anne Saunders actually has made in the chat, and Honor touched on, which is builds again on what we've just been talking about. Charlotte's just been talking about the manual. For someone, layperson looking in outside, how does this system work? Where are the decisions taken? I think it would be, I don't know if it could be done, but in one page, could we explain what decisions get taken where? Would that be possible?
We can certainly have a go.
I mean, I think, because almost what this is missing for me is one of those amazing sort of bubble maps where you see bubbles of different bodies and you work out who from that sits in which board making decisions about what pot of money. It would be an amazing challenge to try and get that simply on one piece of paper. But if it did exist, it would certainly help me and people from outside. And
Oops, Chris, you've gone on mute.
One of the main differences about the new board and our current board is currently our membership is our CCG you've got your CCG chair, transition director, and a governing body lay member. So you've got officers and members from the CCG, but from Hackney and the city, you've just got members. And we're introducing for Hackney and the city officers as well on the board. Some decisions at our local authority level are members taking a decision that then officers are bound to act upon. Sometimes we take a decision that just gives delegated authority to officers further down the line in light of what they subsequently find out about something to take decisions. And I think for the new board, we need to be really clear, because I suspect for some decisions it will be all right for the whole board, members and officers together, to take it. But for other decisions, it might be one or the other. And my sort of practical suggestion for working in the future would be, does your agenda for your meeting, certainly for the next year, possibly for the future once the new legislation is written, need to say, because at the moment we say for approval or for noting, do we need to add after for approval by whom? That would be my suggestion.
A helpful guide.
Thanks.
Yeah. And on Chris, on the local authority decision making requirements, both local authorities are we're waiting on the local authority specific documents that will then form part of part 2 about your schemes of reservation and delegation in terms of who can be present, who needs to make decisions. So those will be incorporated in the part 2 arrangements once we've got them.
Great. And indeed, the chat talking about the work around getting this manual in a state which we can receive it next time. I appreciate that Rachel Tomlinson's name's been put in. Siobhan's thinking about how to bring that together. So thank you to seeing that update in the chat. So I've got John Williams' hand next, then Gary Marlowe.
Thanks, Mark. It's going back. I'm pleased to say here that people talk about how will the public understand this, because I think it's really important that they do have understanding about what's happening in these rooms, virtual rooms. I think it's more about the framing of the document, and maybe it's not a question for the lawyers, but I think one of the things we've been very clear from the start of this work is about the triumvirates, with the kind of the work, the equal partnership between the clinician, the manager, and the public. And I don't really see that in this document now. And I would like to see it come back again, because I think it's a really important thing that we're trying to achieve there. It's an ambition, and it's a brave ambition because of the imbalances of power there. But I do think that's one of the things that we need to keep pushing on. If we're serious about inequalities, we need to keep talking about it. The other issue is I'm not clear, and it may be that I haven't seen it clearly, but where's the link to the Nolan principles in this document?
So again, that's part of the overarching governance arrangements. Sorry, I've just lost your picture and lost your name. Sorry, John. So the Nolan principles are incorporated within the NEL CCG governance, and I guess what we were trying to be mindful of is not over duplicating, but to my mind that forms part of the manual because it governs every single aspect of what you do across the whole ICP rather than being board specific. And so I would see that forming part of your sort of clear overarching manual that governs the whole way you operate as the ICP. And on your other point, I'm very happy if you've got some suggestions around the wording, if you would like to send those to Jonathan, or I'm happy to have a separate conversation with you around that so that we can reflect that.
Okay, thank you very much.
Great, thank you. Gary Marlow.
So I think most things have been covered already, but I just wanted to follow up again, just to sort of reiterate Haron's point that it seems to be a little bit light on clinical involvement. So just that one point. But the other thing I wanted to say was that I completely understand that ICP is not a legal entity, not a legal body. But I think that, or I don't know if there's any point in suggesting this, but I think we should approach it as if it were a legal body, and the manual should be constructed in that way, because even though it may not have any legal authority, it will have moral authority. And I think sort of bearing that in mind, it is important that we put that. We might not be able to take things that we've written down in the manual to a judicial review or to a court, etc. But it still would carry some authority, but would enable us to feel not only more confident in our roles, but also help us in a decision making and in arguing our position. And I think it is important that it is written down because, Mark, you've said that, you're very reassured by the fact that Henry is there, but we can't construct a system that is reliant upon individuals. It needs to be written down. And I think we should therefore approach this as if the ICP were a legal body, knowing full well that it is not.
Yeah, I'd agree. And that's partly why we've done quite formal terms of reference for it. And we have sought to describe a lot of its role as being decision making to try and give it some weight. But I agree that the place to describe the importance of it is in the manual, so long as, just putting my lawyer caveat, you don't say anything that causes problems for the next year. So, but that's the typical lawyer point.
I always like to say things that cause problems.
So Gary, I absolutely agree with you that the reassurance that Sonal's done, our colleagues have done so much work on the connectivity between NEL, CCG and our ICP is reassuring. But the reason it needs to be written down is emphasise the fact that we're spending so long on it, looking at the written down forms we've got in front of us and expecting clarity around the manual and other things next time. I absolutely agree with you. It's got to be written down as well.
And the manual is a really important sort of future-proof corporate memory as well, which is a really important part of this, because obviously if you have people who are really intimately connected and involved with the design, and then they do move on, then you do lose some of that corporate memory. So that's partly also the purpose of the manual, is to actually record that design intention so that someone new can come in and read that and understand why you've got to where you did.
Grand, thank you, Charlotte. So Marianne Fredericks.
Thank you, Chair. It's just a very small minor point, actually. It's on page 43 at the bottom and page 44 when we discuss membership. It says membership of the committees will be reporting to the Health and Wellbeing boards. And then we have the membership. So we have City of London, we have the chairman and the deputy chairman of Community and Children's Services. And then it says one other member from Community and Children's Services who is a member of the Court of Common Council. That is at odds with the current terms of reference that the Community and Children's Services have regarding this committee, where it says that the Chairman of Health and Wellbeing Board to be appointed in addition to the Chairman and Deputy Chairman of the Community and Children's Services Committee. Given that the committee will be reporting back to the Health and Wellbeing Board, I do think there should be clarity around this one other member. It should actually say the Chairman of the Health and Wellbeing Board, simply because the Chairman of the Health and Wellbeing Board does not have to be a member of Community and Children's Services. and there's not always a guarantee that you actually get a membership on that committee. So I do feel that should tie up with the current arrangements and provide clarity around the role of the chair of the Health and Wellbeing Board for the City of London. Thank you.
Marianne, I'm happy to take that back. I mean, obviously we got the membership from the lawyers, so I'll take it back to them. Perhaps you could send the wording through to Jonathan though, just so that I can be specific with the query. Thank you.
Yes, and I have a question about the important nomenclature I'll make in a moment. But before that, Tracy Fletcher.
Thank you, Mark. I suppose just following up on the point that Chris Kennedy made, and the potential, not legal. So Chris was making the point about being absolutely clear where decision making can be made and levels of decision making can be made across the system. And I'm thinking particularly the ICPB, how the ICPB, the Health and Wellbeing Board, and the Neighbourhood Health and Care Board interrelate to each other. I think that we also need to think about that in the context of a little bit further about how those boards will interrelate and who will take, or which of those groups will take what responsibility in a doing sense, a working sense, because there is I think there's a potential of a slight danger here that we're going to get duplication across each of those three groups. And I think one of the things we need to think through, and we can do this outside of this meeting, is practically how will that work? So how do you make sure that you don't end up having the same conversation 3 times in each of those 3 groups, and indeed in any form of operational delivery group? Almost at the same, potentially at the same time, and then the potential of contradiction or duplication emerging. And I think there's a need to work through some practical examples of this, because I worry slightly about how that is going to happen and how we make sure we stick to absolute clear remits, because there's a lot of duplication, particularly in terms of the membership of all 3, indeed 4 of those groups, down to individuals being duplicated.
Yeah, I'd agree, Tracy. So I think part of that is perhaps trying to look ahead to the next couple of meetings and thinking about what you're actually going to be, not specifically the meetings of the ICPB, but generally what, as an ICP, are you going to be thinking about in the next few months? What decisions might you need to be taking, and where are those decisions actually going to be made under the new structures? I think that's a really important part of the process. And it's doing it in the hypothetical is only helpful to a point. Ideally you do think about some concrete examples that are coming up, and really drill down into where those are going to be taken, and where any decision is happening.
Yeah, I mean, if I can just come back on that, I mean, thank you for that. I mean, I've said consistently that this is a journey, and whatever we agree now, we should almost expect to be different in 12 months' time, not least because we're going to be in a different scenario again with the introduction of an ICS, but also a better understanding of what we actually mean by a system and how that will work. So I think in setting these terms of reference, we need to have that clearly in our mind. And I mean, my own view is if these terms of reference don't change, particularly in line with Health and Wellbeing Board and the Neighbourhood Health and Care Board over the course of that period, then I think we're slightly missing the point of a system, because we're going to end up with too much duplication. Is my view. But I recognise I'm looking at this. It's interesting. I'm looking at this in completely different eyes, having had 38 days of it now, and do see it in a very, very different sort of way than I did 40 days ago, which is helpful and very unhelpful.
No, they're definitely evolutionary, and I think all of these arrangements will change quite a bit, although hopefully the sort of key principles around how you're actually working together will remain the same. So I think that's the point to understand. The governance structures will hopefully become much simpler and much more streamlined, but the concepts around how you work together and how you make decisions should remain fairly stable.
Yeah, and I'd say put sort of committee members, attendees on notice, in a sense, that we will have to return to this governance discussion and review how we're getting on. You know, in the tour it says we review annually. Well, no, we're not. Obviously we're going to have to take stock of not only how it's going and how we're transacting business and are we making any difference. Can we see any difference to the way the world is with our new ways of working? But also, are we undertaking the sort of evolution that Tracy's you've just described, and also are we influencing the shape of the ICS and getting in a position where we can then continue our work when the CCG goes and the ICS takes, it has a legislative kind of basis. So we need to kind of keep our eyes on all those different parts to make sure that we can continue as an ICP to do what we need to do. And I think we will be returning to these sorts of discussions with more regularity in the first few months than we would hope to do in subsequent years to come. Gary, I think I saw your hand go up again.
So just to follow on, so I absolutely agree with Tracy, and I think it's really important that when we think about decisions, that we need to be clear about strategic decisions and delivery pragmatic decision making, and that they're different. They need to be done at different, in my view anyway, done at different levels of the system, and certainly delivery decisions shouldn't be second guessed higher up the food chain, as it were.
Yeah,
sure.
Yeah.
Tracy, did you want to come back on at that point now, or is that a legacy hand?
No, I was going to come back.
Yeah.
And well, it's slightly what Gary's just said, although I would follow on from that because Gary previously said actually there needs to be more clinicians on this group if it's going to be representative. I would say there needs to be less people on this group ultimately in the end, and it is a balance. It is, I suppose, there's a clarity to be established as to the difference between assurance and ultimate decision making and approval versus where all of the work gets done and the proposals are generated. If you're getting to the point where you're agreeing quite specific items at this board, then the system is not working because actually most of that work should be done in better informed parts of the system. This board ultimately, at a very high level, in my view, should be seeking assurance that it's following the vision that's been set, that it's been done and taken into account all of the principles that we should be looking for, including the co-production element, and that it fits with the overall financial sustainability envelope. But in terms of the detail, we have about 10,000 people working in City and Hackney or across City and Hackney who are all better versed to understand and to input into what the detail of how we pull that together is. The setting of the vision should be held within this board, and we should be challenged throughout the system to deliver on that. So I'm afraid I probably would disagree with Gary on the sense of necessarily more clinicians, but I would advocate absolutely more clinicians elsewhere throughout the structure, and for them to be driving some of the proposals and the decisions around the proposals that are going to come that we're going to pursue.
Yeah, I must say, I guess I can't really speak totally personally, can I? But in all regards, I absolutely agree with you, Tracy, and I think probably it's a matter of people, having the confidence, and as we start working, people will realise that's ultimately the sort of direction we'll end up heading in, and I would be very supportive of that. Which brings to a point I will make is that, so for example, I see that ultimately, the ultimate assurance here for the ICP, the ultimate sort of setting the strategy here, etc. So with that in mind, I see the area subcommittee working, in case anyone thought they were going to kind of go off and get on with stuff somewhere else. No, it'll. I can almost not see any reason why the area subcommittee would ever meet out with from meeting within the ICPB. That's where it'll transact its work. Now, if there comes a point where, you know, and we'll say, does everyone agree? And most of the time, bearing in mind the history of when we make decisions, and actually we generally reach a consensus. It will be just record, and we will record formally how it's been recorded. Yes, of course. But actually, and if it is a bit difficult, we'll deal with those situations by exception. And if you know that's fine. But other than meeting probably as an area committee to formally sign off the bit of the tour that relates directly to them, I think we would just get on with the work here. And actually, I would expect to see that ideally that consensus continue. And of course, we work to develop that and have those challenging conversations inside of our meetings and outside when we meet elsewhere. So I would hope that that would be our kind of default position and deal with anything else by exception. Karen, you've got your hand up, and then I think Chris.
Just a quick one to Tracy's point. So Tracy, when I mentioned about clinical leadership, it wasn't necessarily mean increasing the number of clinicians. I meant how we can make more relevant, meaningful membership. That's what I meant.
Fair enough. Chris Kennedy, you've had your hand up for a while, so it's probably aching a bit. So you go.
Thank you. I just wanted to build on the reference that Marianne made to health and wellbeing boards. And actually, if you Control F health and wellbeing board and strategy through this terms of reference, you get mentions that I'm very pleased to see about working in close partnership in terms of the ICPB working in close partnership with the health and wellbeing boards, aligning the ICP's vision and strategy to the health and wellbeing strategy. That's great. Then when it gets to accountability and reporting at 10.4, we are talking about this on page 36. I'm just going to find it. I'm glad I wrote the page down. The ICPB receiving reports from the health and wellbeing boards and making recommendations to the health and wellbeing boards on matters. I wondered if that doesn't work in both directions, especially if you think about the ICPB being closer to the delivery of health and immediate health and care matters for our residents, and the health and wellbeing board looking a bit wider at the wider determinants of health, specifically in the remit that it has set down for itself. And so sometimes the reference and the recommendation might be from the health and wellbeing board to the integrated care partnership board.
You can make it a mutual.
So yeah, make it mutual, but also always have in our heads Tracy's brilliant point about not duplicating work and being clear about what happens where. And I think finding an example, finding something we want to do soon and seeing where the visioning, strategy, quality assurance and work for it is done in different places will really help us be clear. I'm not quite sure what that is. I think I might have an idea, but that's for later.
Yeah. And I think some of that can go into the manual as well. Sorry to keep banging on about it, but I think that that is really the missing link here in terms of bringing it together and describing how the various parts work, looking at who's on each part, because you might want in the manual a table that shows the membership of each part, so that overall you can see across the piece who's on each board group, and you can see where the commonalities are, and perhaps, you know, then ultimately that will inform hopefully streamlining some of the numbers.
Okay, thank you, Charlotte. So Ida Skoulos.
Yeah, I just want to ask, in your manual, are there going to be any reference to the public? Because I think no matter what, clinicians or whatever you're doing it for the community. So I just want to know what happens. I don't see any reference anywhere for the public, because Health and Wellbeing Board doesn't have a public member. I know Health Watch is part of it, but again, Health Watch also needs to be monitored by the public. So it's just looking at, you know, conflict of interest. So where do the public sit to monitor this?
I am probably not best placed to answer that question, actually, in terms of the overall ICP link with the public. Jonathan, you've got your hand up. Do you want to comment on that?
Yeah, Ida, you're right. I mean, obviously, there's Health Watch listed as members. I think having elected members on board is very unusual. It doesn't happen at this sort of board almost anywhere else in the country, and it's not a direct replacement for public involvement, but it brings that public view. And then there is the People in Place group, which is starting to establish itself, which is taking on some of the responsibilities of the PPI committee. And there's also the VCS Assembly, the HCVS are developing have got funding for a year to develop ways of reaching out to particularly communities that have struggled to engage with the system before. So there's a lot there that I think we should be proud of. But I think you're right. We haven't articulated it well enough, and that would be something for not. I think the manual is very much something for people working within the system to understand how their role works within this quite complicated governance. I think that the guide that we've written for the public and this one-pager, that the one-page challenge that Chris has set us, these are places where we need to articulate all of this better. And if it's not clear, then clearly there's still work to do. So that's really helpful, Ida.
Thanks, Jonathan. So Tracy again.
Actually, I was just going to add to Jonathan's point, and in response to Ida. So I think there's one level around the visioning, Ida, and then there's another level around getting into the detail and the nuts and bolts that lie behind any sort of proposal. And I think one of the things that this board needs to make sure it's assuring itself of is, as work is done throughout the system, then there's always the question as has that involved a degree of co-production? Has it involved people who are either affected within that community or affected within that condition or affected within that geographical area? So I guess there's two levels, and one of the things I think in the manual, as Jonathan refers to, is us being absolutely clear that is. In the way that you pull something together, you think about finance. You also pull something. You're also absolutely mindful of you've involved the local population or the local group, the local community, whatever it may be, in thinking through what is where should we be going with any particular initiative. So I think it's on two different levels, and I think that in my own personal view is I think the one I'm describing is really, really important, because actually often the devil is in the detail in terms of understanding how these things work for people within the communities, which is sometimes lost when you describe it at a very broad level.
I would add that there's a kind of rich discussion as well in the chat, picking up on some of these points as well. I don't know if anybody wants to articulate those out loud. Certainly we can read whilst you think about that. I'll just make a small point about the nomenclature, really, is that, but I think it's important that the role that I currently hold is not a borough chair. Oops, who's that needs to go on mute? Thank you. I'm not, and at the North East London level, that's now been agreed that the term borough chair isn't what the old CCG chairs would be called, principally because I don't just represent a borough, and so I did say that I wasn't prepared to trample over 900 years of history in the Corporation of the City of London, and actually everyone readily agreed with that when I was talking to my chair colleagues and others at NEL. So the title is City and Hackney Chair, NEL CCG. And that will be replicated by the 7 old CCG chairs. And of course, it's only a year. Well, in fact, what is it, 10.5 months now? Because as we know, the CCG is in its state of transition until it disappears as the ICS forms. So I just think it's important to make that point. There was also the other point, which was actually that the understanding was that post would carry on chairing the area subcommittee, because obviously my role sits on the ICB, the NEL CCG board, as indeed does the associate lay member. But in fact, I talking with colleagues locally and across the board, they thought it would be sensible that the role I hold would continue to chair the area subcommittee for the 10.5 months that it exists in its current form, if no other reason, just to maintain that continuity. So I thought I'd make both those points, really.
That's fine, Mark. We'll update that. I mean, that the borough chair is just the term used in the constitution, so that's why it's.
I know, and it was. They just needed to find something to call it. But it took a while before that other name came, and it is a bit clunky. But there we go.
Fine, and we'll update the chairing. That's fine as well.
Good. Okay. Thank you. So I can't see more hands, and I think any other points I was going to make have been made very articulately already. So I'm just stalling a little. So Charlotte, did you want to kind of have a moment just to kind of summarize what you've heard, what you're going to take away, and maybe Jonathan as well, what we will, our expectations, how our expectations for what we will receive in the June meeting will be managed?
Yeah, sure. Thank you. So really, really helpful. And thank you so much for asking the questions that you have. I'm really happy to answer any more that you suddenly think of after the meeting or when you look at the terms of reference in more detail. So please do, feel free to contact us. But really helpful. So we'll take away the comments that we've got and, have another look at those particular parts of the terms of reference. And then I think the main piece of work is around the manual. So Jonathan, perhaps I'll hand over to you and you can pick up on that.
Thank you to Charlotte and Steve for all the work they've done and for coming today. And I think Charlotte in particular is really good at explaining quite complex technical stuff in a way that feels relevant to the practical work that we do on this group. So that's really appreciated. So there's a one pager. I think Chris's challenge is really useful because it forces you to think about whether this makes sense or not. And so I think trying to get this on one page in a way that the public will understand is going to be difficult, but I think it's going to be a really worthwhile exercise. It'll inform some of our work in terms of reviewing this over the next few months. And then the manual for staff. So there is a manual at NEL level, and I know work is happening in the other ICPs that we can draw on. So I think just allowing staff to understand how they fit into the system and kind of what you need to do in order to get approval for things and where things need to go. That's going to be incredibly useful. And as Mark said, feedback today really helpful. Any additional feedback, particularly on some of the things we might have missed. So Marianne had pointed out some of that. So any of that small detail, just drop me a line and we'll make sure that's incorporated into the next version. And then finally, I think this point that both Tracy and Chris and others made about it's the interrelationship between different groups and real clarity over what happens at Health and Wellbeing Board, what happens at ICPB, what happens at Neighbourhood Healthcare Board and in other places is the thing that we really need to get right. So we don't need to get it right today, but that's something that will be a real test in terms of how we review the governance, that we've got absolute clarity over what happens in which place. But thank you very much for all your feedback.
That's very helpful summary. Thank you, Jonathan. And I add my thanks to you and the team and Charlotte and Steve as well for all the enormous amount of work going into this. But so we will return to it between now and June and then more formally at our next meeting in June. So can I just ask the City ICB to note the report? There are a few nods. Yeah, thank you. And Hackney ICB, can I ask them to note the report as well?
Noted.
Thank you very much. Right, so let's move on. Actually, it's so the monthly finance report. I'm handing over to you, Sunil. I know that it's early in the financial year, so you're just going to give us a verbal update, which you already sort of flagged up when you spoke earlier, but I'll hand over to you.
Thank you, Mark. I'll do a double act with Ian Williams.
Oh, Ian, sorry, Ian, I hadn't seen you on the call. Sorry.
Ian, give an update on the LBH side as well. So, Ian, shall I start off?
Yeah, that's great.
Okay,
Thanks,
great.
Ian.
So just to give everyone an update on the City and Hackney ICP and the NEL CCG plan position for this year. So about a week ago, we submitted our overarching North East London plan to our regulator, and that plan was for the first half of this financial year. So we're receiving allocation funding for 6 months, and then there'll be another 6 months worth of allocation for the second half of the year. But our initial submission was break even with an underlying deficit or financial gap of around 22 odd million pounds, but that relative to a 1.9 million pound allocation is manageable. But we are operating at risk in the first 6 months of the year because we've got the ongoing programme of work around COVID and vaccination, the restart and recovery of the elective backlog, workforce challenges to address, along with other programme costs like prescribing and CHC that are going to likely to create cost pressures on a year-to-go basis. But the operating plan has gone in, and that operating plan is break-even, and we're working with system partners to manage the finances, the underpinning activity, and all the risks and the challenges that comes with. Next steps now are to disaggregate the City and Hackney ICP plan and put together specific budgets, and those budgets will be presented to this group, this committee, in June in terms of the overarching plan update, what that looks like for City and Hackney ICP, what that looks like for the NEL CCG and system. So currently work in progress, and for this month we don't have a month-end report. As I mentioned earlier on, it doesn't happen in April, to be reported in May, so we'll bring that back in due course. Take a pause there. Happy to take questions.
Any hands? Not at the moment. Oh, hang on, Chris Kennedy.
Can you say the underlying gap again?
22 million.
Okay.
That relative to a 1.9 million pound allocation is we believe manageable, and we're working with providers and our system partners and within CCG internally to address that. So we've declared a break even.
Thanks.
Ian, do you want to come in now?
Yes, certainly. Good morning, everybody. Hope you're all well. So in terms of where we are in terms of the council's outturn forecast for 2021, I've been working closely with the team as we look to, and it is that exciting, isn't it?
Oh dear, I think that's a button required pressing. Unfortunately,
every time I mention statement of accounts and closure of accounts, I get that reaction from virtually everybody, including some of my accountants, which does worry me. But anyway.
Aaron, do you want to go on mute?
So financial year 2021, obviously it's still early in the closure of accounts process, but going through the initial draft with the team only this morning, what's encouraging is that what we were forecasting at the last meeting, which was a modest overspend, including all things after applying the extra COVID monies we've received, it's looking there or thereabouts in terms of what we were predicting. So that's encouraging. My intention is to take a draft outturn statement to Cabinet in June, which is pretty much in line with normal reporting timetables, which is real great effort by everyone, budget holders and the finance teams, given the impacts of COVID, but also the double whammy that the council's facing with regards to the criminal cyber attack, which, as you know, has really significantly impacted a number of our key core systems, and obviously that then impacts upon how we pull together the financial positions. So turning to 21-22 financial year, obviously members will be aware of the reports we brought outlining the budget ambitions of the council in that financial year, the savings we identified, our approach to bridging the gap. As always, we set a balanced budget for 21-22 as we're required to. Councillor Chapman and I have been working very closely with the Mayor, with all Cabinet members, to make sure that there's that real ownership of budget proposals for the current financial year, and in particular, real scrutiny around the deliverability and the delivery of the savings that we'd agreed. That is all underway and in train. Attention is now turned, not surprisingly, to financial year 22-23. We're already starting work on developing proposals to balance the budget for 22-23, but I appreciate I sound a bit like a broken record in terms of saying that, again, we find ourselves in a period of uncertainty in terms of financial position, given we've only had a one-year spending round, and we await whatever the government will do in terms of spending review periods for those parts of the public sector that haven't had announcements yet. So we're having to make some judgments around the financial resources that will be available to us, and indeed the flexibilities that we'll have in terms of things like council tax, as an example. You know, currently, as we sort of sit here now, we're only allowed to increase council tax by 1.99%. There's no clarity on and the adult social care precept beyond the current financial year. So again, we're working that through with members, in addition to the uncertainties of COVID. So that's sort of a very quick overview from me, Chair, but happy to take any questions or follow up offline with people if they want to have a more detailed discussion. Thank you.
Thank you, Ian. Andrew Carter, you have your hand.
I do. Mark Jarvis isn't here, so just if I can get an even bigger yawn than Ian's one, just to make sure the city doesn't feel left out. Again, we're in the same position in terms of preparing our outturn. There's a lot of work done by our finance department. Overall, we are looking at a slight budget underspend for this year, and we are looking at a balanced budget. Members very gratefully, we as a department agreed a smaller 6% savings target for adult social care and children's social care. So we are looking at a balanced budget.
Great, thank you, Andrew. So giving them pause to take that in. No other hands going up, so thank you for the updates, everybody. Good, as ever in this early part of the financial year, so there's obviously less to get our teeth into. Right, no further comments, so can I just ask, and therefore we'll move on, City ICB to note the report?
Yep.
Thank you very much, and Hackney ICB to note the update?
Noted.
Thank you very much. Right, so let's move on to the monthly, well, the workstream risk registers. Matt Nell, are you on? I haven't seen you on the.
Hi, Mark. Yes, I've been.
Yeah. Thank you, Matt. Thanks for joining us. Do you want to introduce it?
Of course.
Thank you.
Thanks, Mark. So we have this month's risk registers in totality, including the detailed breakdowns from workstreams starting from page 59 of the circulated papers. Last month's meeting, there was some concern raised regarding the children and young people's risk number 19, regarding safeguarding arrangements in place. That risk has remained static on a month-to-month basis. And then also we talked a little bit about risk number 20 in the urgent care work stream regarding health inequalities. That risk has reduced from a 16 and a red status last month to a 12 and an amber status this month, as the team have progressed in partnership work with neighbourhoods, and PCNs have made some progress in this area of work. We are continuing to work with all the work streams to update the risk registers, and particularly to bring them up to a Q1 21-22 position next month. With regards to other movements through the registers, we've had one movement in the children's risk register. That's number 15 on page 67, has moved to a 15 and a red status, so that has gone up. There's detail on page 81 regarding the actions and mitigations in place on that one. In planned care, we've had risk number 2 reduced from a 15 to a 12, so that's from a red to an amber status. And that risk is regarding continuing healthcare assessments, which progress is picking up on clearing those lists down. Happy to either take any questions or take any questions back to the work streams.
Right, just seeing hands. There we go. Sunil, in fact, John. Sorry, John, you had your hand up first. John Williams.
Yeah, thanks, Matthew. It refers to the risk you just talked about, the CAMS risk for adolescents, and I've looked at the page 81 as well. It's clearly a really stretched area now. Is there any extra resources going to go into this area? Because we had Paul Camius come to the Health Watch board meeting, and he was very kind of concerned about this issue, but also recognising that, you know, a real serious need, although we seem to have enough beds in our area to actually kind of cope at the moment. But it does seem to be kind of just an area that's going to just get worse at the moment. So what extra resources can we put into this area?
I think Sunil may be able to respond on that one, but otherwise I can take that back to the team and we can bring an update back next month.
I think we'll probably bring an update back to you, John, on that, if you don't mind, or maybe beforehand and send out a com.
Okay, so we'll look out for an update on the mitigations on that one. So sort of, you actually had your hand up as well anyway, didn't you?
Thank you, Mark. Just wanted to sort of defer to Rachel in a moment to maybe give an update on the risk framework program of work that's taking place within the CCG, within the ICPs, and Matt's part and parcel of that. And maybe just ask Rachel to give a brief update on that. I'm mindful that these documents are very long and complex and quite detailed, so we're looking at our risk reporting arrangements going forward, and there may be some changes coming our way. But wondering if Rachel's on the line just to sort of give a brief update on that.
Yeah, very happy to. So I'm helping to lead in risk management across the whole of NEL. So in terms of the policy and strategy, and then how that works down within the ICPs. I think with a new structure, it gives us an opportunity to kind of reevaluate how we look at risk and how we report risk, especially to these meetings. We're still working through the details, but I think it's helpful that we, as an ICPB, focus on the risks that will impact on the system and the stability of the system, and especially if there are, in addition to that, ICP finances from the health point of view. So I'm looking to kind of just talking to Tracy and also to Siobhan just about how we do that in the most effective way.
Thank you.
Oops, right. Honor, you've got your hand up.
I've just put it in the chat. I just think it would be helpful to have some sense about trends and around child self-harm, adolescent self-harm and suicides, particularly over this period.
Thanks, Honor. I'll take that away, and we'll look at getting
Anne's last meeting. Oops, sorry. Oh.
Maybe a more substantial brief to the next meeting from the Children and Young People team on a few of these areas.
Right. Okay. Sorry about that. I meant to just didn't quite hit the mute button in time. Good. Tracy, you're next. Oh no, Chris Kennedy, you've got your hand up. Beg your pardon.
Thank you. Mine was just to say, I think, congratulations on the childhood IMS risk, although it's remained the same, that it hasn't gone up, because actually it was for that last quarter when we were in second wave. I do note and I think everyone's very grateful for the extra 800,000 that the CCG put in, and I presume that helped stop that from going up. But I was expecting to have seen it had risen, and it hadn't. So I just thought, well done to everyone in the system. Thank you.
And I think it's interesting the system's thinking about the learning from dealing with people who are cautious about vaccination, whether it's flu, COVID-19, all that has been exposed about that, and learning around how we can develop our childhood immunisation, and indeed other type of adult immunisation programs. And that 800,000 is also focused on that wider whole piece, which is good to see. Tracy.
I think the point about what is the risk framework and what is the assurance framework either at an ICS level and then particularly at an ICP level is quite an important point. And what do we need to think about as a board in terms of being in being assured that we're moving forward against a set of strategic objectives? And this feels that there's elements of this that feel quite, I suppose, operational, and it's missing some sort of assessment around how do we assure ourselves we're moving forward against a set of strategic objectives, and we understand what the risks are associated with those. So without wishing to sound like we need to have a look at everything, my view is I think we do need to have a look at how do we bring that together. I mean, I find it interesting that there's a risk on here regarding the Homerton. I didn't know it was going to be on there. It feels, and that, it feels quite. It feels very, very granular and very operational, and yet as a board, I think what we also need to understand is how we're making progress against some broad overarching strategic aims and objectives.
Rachel, did you want to come in on that point amongst others?
Yeah, no, I think that's completely right, that we do need this meeting needs to be looking at the high level risks against the kind of corporate strategic objectives. And I've got I'll talk to Tracy outside of this meeting, just some ideas of the best way to do that. So actually that you are looking at the risks that are not kind of lower level operational ones, but are more strategic.
Mm. I had, when I was reading it, I did have that sense as we move into our ICPB that we do need to undertake that review. Really, the risk register is such a long, weighty document. It felt that it wasn't quite well the way it's structured, but also the actual number, and some of them need to be reviewed in that light. I think I really welcome that. Good. Okay. Just seeing if there are any more hands. Matt, did you want to say anything in conclusion?
No, I think that's it. I'll take those couple of points away, and just to say, yes, there is, I think, recognition across the whole of NEL that risk is a key area of work for the next few weeks. There are kind of some proposals floating around, so I think we will see some change on this front pretty rapidly.
Great. Okay. Thank you, Matt. Good. So in that case, can we move on to? No, that's just a bit more chatter. No more hands. No. Okay. Just some more comments from Anne. Thank you. In the chat. So can I ask the City ICB to note the risk registers, please?
Yeah.
Thank you very much. And Hackney ICB to note the register as well.
Noted.
Thank you. Tracy, you had your hand up again. Did you want to just say that before we noted it? Let's pretend you have spoken before we noted it.
Yeah, really, really sorry. Just picking up on Anne's point, and just so I'll throw this in terms of how we should be thinking as a system going forward, and picking up one that I would particularly know about. So the significant staffing and recruitment issues in Homerton Community Paediatric Services, approximately 50% of doctors. And then the update, CCG requested staffing plan. I mean, what we need to get to is identifying where the operational issue sits with regards to a overall strategic objective, and that might be something that we want to raise. The other issue about that is we need to get to a point where each of the individual organisations are recognising that. So the whole language of the CCG requested staffing plan and HUH submitted, actually, if I think it's going to be compromising the strategic objectives, or if Dylan thinks, from the Homerton's perspective, or if Paul thinks from ELF's perspective, then we need to be part and parcel of how this is pulled together and raising those issues. Otherwise, we're not moving to a system way of working. We're retaining a very old way of working. So I'll just throw that in there in terms of my continual approach of challenge, really. But it does come back to, I do think we need to think about how we manage this going forward.
Yeah, I agree, and that language is so important, actually, and that's
and
the language is a hangover from when it was written, probably in February or something.
Yeah. So Anne will be reassured if we're raising that, or the Homerton people are raising that, as opposed to this perception that it's this questions asked and a response is given. It is that collective responsibility to manage where there are going to be issues, and that's what we've got to move to.
Yeah. I think there's lots of nods, and I would agree. So that was worth waiting for. Thank you, Tracy. But anyway, we have noted it, so let's move on. So thank you. No other hands, so we will move on then. So any other business? We're at that point. No. Okay. So before I turn to reflections, there's one of our midst is their last meeting. Anne Canning, it's your last tour in this on this event. I don't know where is your camera on. I can't see. But Anne, obviously, with your last meeting, we must owe you an enormous debt of thanks. You've certainly been here, gone through the history of all our different iterations and attempts to develop our integrative ways of working, but so much more besides. But I can't hope to kind of do justice to all of it. But I think you'll be greatly missed. And I know I'm sure I speak on behalf of us all. I wish you all the very best in what you turn your skills and interests to next. So thank you very much for all your efforts and work with this group. Thank you. And there'll be some chats. Yeah, there's some already dropping into the chat. So after that, any other reflections on our work here today? I have to say we're leaving a bit early, so I can leave this pause even longer this time. Honor.
What a surprise. Given that I come to both meetings, the local outbreak board and this meeting, I'm just aware of the appreciable difference between the two, and I wondered for those of you who also were in both noticed it. And I think there's something. I mean, there's the sole focus of the local outbreak board and a lot of its information, but there's a lot of really interesting and rich thinking. That's not to say it doesn't happen here, but there's something. I think there's an energy about the local outbreak board that I wonder if we couldn't think about how we generate some part of it for here. I think we've talked about some really interesting things though this morning together as integrated commissioning partnership board, and I think we've used interesting words. I mean, I know that the anchor organisations has a particular meaning, but anchor is a great metaphor, and we've talked about place. We've also used words like triumvirate and moral authority. I've written some of these things down. It's rare to be in a meeting where you have this richness of discourse, and I was very intrigued by the notion of the manual having design intention inside it. So I think there's something really interesting and complex in the thinking that goes on here, and I think the minutes reflect it. Actually, I think the minutes are good because they show some of the richness of that discourse. So I was just intrigued today at both the difference and then some of the depth of the conversation we've been able to have.
And I must say, when you consider we spent not quite, but the best part of an hour talking about terms of reference and governance, to then also reflect that you've just said something like that, I think is a testament to the quality of our work, actually. Chris.
Thank you. We have had, as a local authority, to go back to meeting in person. So on Monday, I had to go into the council chamber. I was required by law so to do. Well, obviously it didn't have to be in the council chamber, but our cabinet procurement and insourcing committee had to meet in person. And while it was a bit rushed, forced upon us, and if given a choice, we would have stayed in virtual meetings for another 3 months, like Parliament is allowing itself to do. Nonetheless, we did it. And actually, it was great to see colleagues. And I have to confess, myself and a couple of colleagues, we went to the pub afterwards. And I just reflected, there was a point today where I would love to have actually physically been in the room with everybody, because it was a point that it felt we were all coalescing around, and that just being able to look people in the eye, someone can throw in a casual joke, you don't have to read it in the chat, and I miss that. I just wanted to say I miss that, and I look forward to seeing you all in person. That's what I wanted to say. Thank you.
Well, here to that from me. Good. Well, any other contributions? Oh, Jonathan, okay.
Just on that, I wondered what that meant for the next meeting of ICB, given that it's a council meeting in some senses as well as a partnership meeting, and whether that technically needs to be held non-virtually.
Well, we can, I'm sure, canvass views on that outside the meeting. Obviously, there's the practicalities of this number of people and, you know, still social distancing restrictions and things are moving obviously quite quickly in that regard. But I don't think we need to, I don't think we can. We could take a straw poll. Who hands up who'd like to be seen, you know, face to face sooner rather than later. But I think it's a bit unfair to expect that here. But I think we should definitely canvass thoughts and views about it outside the meeting. And actually, we all actually secretly want to see the cuckoo clock to see if it, because that's Gary's good point, Gary. Yeah, you could bring it along, perhaps.
I will.
Good. All right. Enough of this lightheartedness. I think we've had all our hands are up. Oh, I think we have one left. Sorry, I beg your pardon. Who's this? Oh, it's you, Jonathan. Okay, right. Therefore, let's draw this meeting to a close. Thank you very much for everyone's time. See you all soon. If not before, see you in June. Great. Cheerio. Thanks. Bye.
Bye. Thank you.
Thank you, everyone.